Usually when we talk about a medical diagnosis, there is this expectation of like visual precision.
Right, like you want to see exactly what's wrong.
Exactly. It's like engineering. You know, you break your arm, the x-ray shows that jagged white line of a fractured radius, and the doctor just points at the screen.
Broken or not broken. It's a clean binary system.
Yeah, we like things to be visible, to be categorized, to be fixed with a cast or a stitch. But then you step into the world of systemic physiology, and suddenly, well, that x-ray machine is entirely
Oh,
useless.
completely useless. You are looking at a diagnostic landscape that is entirely invisible.
Right, you're dealing with microscopic feedback loops, chemical messengers floating in the bloodstream, and a body that is constantly, desperately trying to balance itself on this physiological tightrope.
And nowhere is that balancing act more critical or honestly more complex than how the human body handles temperature.
Absolutely. So if you are sitting there listening to this, prepping for a massive nursing exam, or even if you just want to understand the sheer terrifying miracle of human survival, you are in the right place. We're going to take the dense, intimidating physiological pathways from your clinical sources and transform them into, the kind of intuitive understanding you actually need.
Yeah, the kind you need when you are on the floor at 2 in the morning looking at a patient whose vital signs are crashing.
Because simply memorizing a list of facts won't save that patient. Rote memorization fails under pressure, right?
It absolutely does. You need to understand the underlying mechanics,
Yeah.
the why and the how of every single symptom.
Right, because knowledge only becomes clinical judgment when it's deeply understood and practically applied.
Exactly. We have to look at thermoregulation not just as a static number on a vital signs chart, but as dynamic, continuous life or death process, one that involves almost every organ system in the body.
Okay, let's unpack this. Let's establish our baseline. What are we actually talking about when we say thermoregulation?
Well, the clinical definition really centers on the human body's capability of regulating its internal temperature at a near constant value.
A near constant value. So it's the absolute cornerstone of optimal physiologic function.
It is. If this one system fails, cellular metabolism breaks down, proteins denature, and everything else just starts to unravel.
An optimal physiologic function is highly, highly demanding, right? It only happens when this near constant core temperature is maintained within a very specific, narrow window.
Very narrow. For your exam, you need to know that the state of normal is clinically referred to as normothermia.
Normothermia, got it. And what are the normal range numbers you need to burn into your memory?
The normal range is 36.2 degrees Celsius to 37.6 degrees Celsius.
And if you're working in Fahrenheit?
That is 97.0 degrees to 100 degrees Fahrenheit. The average target temperature, like the classic number we all hear referenced, is 37 degrees Celsius.
Or 98.6 degrees Fahrenheit. So we have a window of barely over 1 degree Celsius, 36.2 to 37.6. But there's a crucial distinction here that seems like a massive trap for an exam question.
Oh, it definitely is a trap.
Because we are talking about core body temperature, not surface temperature, right?
That is a vital clinical distinction. The core temperature, so the temperature of your deep internal organs like the heart, liver, and brain, is actually about 0.5 degrees Celsius higher than the skin surface temperature.
Wait, really? So it's almost a full degree Fahrenheit hotter on the inside?
Yeah, roughly 0.9 degrees Fahrenheit higher. You have to conceptualize the body as having two thermal compartments.
Okay, 2 compartments. Walk me through that.
So the outer compartment is the shell. That's the skin, the subcutaneous tissue, the superficial muscles. This shell is constantly interacting with the environment, acting as, well, a thermal buffer.
And the inner compartment is the core.
Right. The core is heavily protected. It houses the vital organs, and it runs hotter because it is the center of metabolic activity.
The surface is the shield, and the core is the furnace. I love that. I also notice in the sources that even within that tight, normal range, temperatures aren't perfectly static.
No, they're not. They fluctuate naturally.
Right, we have a natural circadian variation. The amplitude is about 0.8 to 1.0 degrees Celsius over a 24-hour period.
Exactly. It seems your temperature hits its absolute lowest point right in the middle of your usual sleeping cycle.
And then as you wake up, it begins to climb, peaks late in your active daytime period, and then slowly decreases again as you approach bedtime.
It is a profound biological rhythm, honestly, and it is intrinsically linked to sleep architecture.
Oh, interesting. How so?
Well, the drop in core body temperature is actually one of the primary physiological triggers that initiates sleep. The brain's internal set point intentionally lowers itself to conserve energy during rest.
That makes so much sense. But from a clinical assessment standpoint, the key takeaway is that when a patient's temperature fluctuates outside of that defined normal range of 36.2 to 37.6 Celsius, it is a glaring red flag.
A massive red flag. It tells you immediately that one of three things is happening.
A pathological disease process, extreme strenuous activity overwhelming the system, or extreme environmental exposure.
Exactly. So if optimal function depends entirely on staying within this incredibly narrow 1.5 degrees Celsius window, the immediate question is how?
Yeah, how does a biological organism that walks through freezing winters and scorching summers act as its own highly precise internal thermostat?
The answer lies deep inside the brain, in a structure called the hypothalamus.
That hypothalamus.
To understand thermoregulation, you have to understand the project manager. The hypothalamus is located below the thalamus, within an area called the diencephalon.
Okay, so if you picture the architecture of the brain, it's this tiny, incredibly vital region wedged right between the primitive midbrain and the higher functioning cerebrum.
Yes, and this specific cluster of neurons establishes the body's set point.
The target temperature, usually hovering right around that 37 degrees Celsius mark.
Right, and it defends that set point through a massive, body-wide negative feedback system.
Because the hypothalamus itself doesn't just guess what the temperature is, right? It requires a constant, unending stream of data.
Unending. It relies on a vast network of sensory neurons called thermoreceptors. You have peripheral thermoreceptors embedded all over your skin.
And their entire job is just to constantly sense the outside world. Are we in a snowstorm? Are we in a sauna?
Exactly. Then you have central thermoreceptors.
Yeah.
These are located deep within the spinal cord, inside the abdominal organs, and even within the hypothalamus itself.
So they monitor the temperature of the blood flowing through the core.
Yes. These receptors are firing action potentials second by second, routing signals back up the spinal cord to the diencephalon.
It really functions exactly like a highly advanced smart home climate system. The sensors out in the living room and the bedrooms are constantly pinging the main control hub with the current temperature, and the hub decides whether to kick on the furnace or the air conditioning.
That's a perfect analogy. So let's trace the actual neurochemical wiring of this system. If those sensors tell the hub that the house is getting dangerously cold, the body initiates the warming cascade.
The warming cascade. The sources highlight this as absolute high-yield pathophysiology for any nursing exam.
Oh yeah, it bridges both the endocrine system and the sympathetic nervous system, which is why it is tested so heavily. You really have to know the sequence.
Okay, let's break down the endocrine side first, the hormonal cascade.
Right. When the central and peripheral thermoreceptors signal a drop in body temperature, the hypothalamus goes to work. The first step is that the hypothalamus secretes a highly specific hormone called TSH-RH.
TSHRH, that stands for a thyrotropin-releasing hormone.
Exactly. Hypothalamus secretes TSH-RH.
Okay, so that hormone is a messenger. Where does it go?
It travels a very short distance, right down the pituitary stalk to the anterior pituitary gland.
The anterior pituitary. And what does it do when it gets there?
The arrival of TSH-RH stimulates the anterior pituitary to release its own hormone TSH, or thyroid-stimulating hormone.
Step 2. Anterior pituitary releases TSH, tracking that. So now we have a hormone entering the general systemic circulation.
Exactly. TSH travels through the bloodstream until it reaches the thyroid gland, which is situated in the anterior of your neck.
And the thyroid gland receives the TSH signal and responds by releasing thyroxine,
Also known clinically as T4.
Step 3. Thyroid releases thyroxine, or T4. And thyroxine is a major metabolic regulator, right?
It is, but the cascade doesn't stop there. Here is the real crescendo of the warming response. Thyroxine circulates through the blood and activates the adrenal medulla.
The inner portion of the adrenal gland sitting on top of your kidneys.
Right. This activation causes the adrenal medulla to dump epinephrine into the bloodstream.
Wait, let me pause right there. Epinephrine is adrenaline.
It is.
Whenever epinephrine comes up in clinical scenarios, it is almost always in the context of the sympathetic nervous system's fight or flight response. You see a bear, your heart rate skyrockets, your bronchioles dilate so you can take in more oxygen, and you run for your life.
Yeah, that's the classic association.
So why is the body deploying the ultimate survival panic hormone just because a patient's core temperature dropped a fraction of a degree?
What's fascinating here is how the body repurposes its physiological tools. We heavily associate epinephrine with psychological stress and physical danger. But if you zoom into the cellular level, epinephrine is fundamentally a metabolic accelerator.
A metabolic accelerator, so its job is to liberate energy.
Exactly. When it floods the system during a cold stressor, it drastically raises the body's basal metabolic rate. It binds to receptors on liver and muscle cells and stimulates a massive increase in glycolysis.
The chemical breakdown of glucose to release cellular energy.
Right. And the crucial thing about glycolysis and really all rapid metabolic processes is that they are not perfectly efficient. They throw off a significant amount of heat as a chemical byproduct.
Ah, so it is not just fight or flight. It is like burn the fuel to stay alive. The body is using the stress hormone to literally stoke the cellular fires.
That is precisely what is happening. Furthermore, epinephrine binds to alpha-adrenergic receptors in the peripheral blood vessels, causing widespread, intense vasoconstriction.
It tightens the blood vessels in the skin and extremities.
Yeah, to lock whatever heat you are generating deep inside the core. It is a highly coordinated chemical defense.
And while this entire hormonal cascade, the TSHRH to TSH to thyroxine to epinephrine, is playing out in the bloodstream, the nervous system is running a parallel defense strategy, isn't it?
Yes, the hypothalamus doesn't just rely on the slow systemic delivery of hormones. It uses the instant hardwired neural network as well.
So it sends immediate signals down the sympathetic nervous system.
Exactly. These neural pathways trigger the adrenal cortex and the motor neurons to dramatically increase skeletal muscle tone.
You feel this initially as a stiffness when you walk outside into the freezing cold.
Right, and if the temperature continues to drop, that increased muscle tone escalates into involuntary rapid muscle oscillations, shivering. It is just rapid, rhythmic muscle contraction and relaxation. But because skeletal muscle makes up such a massive percentage of human body weight, this rapid movement generates an enormous amount of physical friction and metabolic heat.
So it's highly demanding, burning through oxygen and glucose, but incredibly effective at raising the core temperature quickly.
Very effective.
If we go back to the smart home analogy, the hub realizes the temperature is dropping, so it turns on the chemical furnace via epinephrine and thyroxine. It physically starts vibrating the floorboards by shivering to generate mechanical heat, and it slams all the windows shut through sympathetic vasoconstriction.
It is a violent, energy-intensive reaction to defend that 77-degree set point. But because this is a negative feedback loop, it works in reverse with equal elegance.
So let's examine the cooling cascade. If the body gets too hot, say a patient is out doing yard work in July, or they have a heavy fever that is breaking, the central thermoreceptors send a frantic too hot signal to the hypothalamus,
So the hypothalamus immediately halts the secretion of TSHRH.
which means the anterior pituitary stops sending TSH, the thyroid stops secreting thyroxine, and the adrenal medulla stops dumping epinephrine.
Right. The metabolic furnace is effectively dialed all the way back to baseline. Simultaneously, the sympathetic nervous system reverses its neural commands. It stops sending the constant vasoconstriction signals to the peripheral blood vessels.
Which leads to vasodilation. The blood vessels in the skin widen, becoming engorged with hot blood from the core, trying to release that heat into the environment.
It also decreases skeletal muscle tone to prevent any excess heat production from movement. You feel this as the lethargy and heaviness that washes over you on a sweltering day.
Oh, wow. Yeah, that heavy feeling.
But crucially, the sympathetic nervous system initiates sweat production. Cholinergic sympathetic fibers stimulate the eccrine sweat glands scattered across the skin to rapidly produce fluid.
And as that perspiration is pushed to the surface of the skin and evaporates into the air, it dissipates a massive amount of thermal energy.
The furnace shuts down, the windows fly open to let the heat out, and the evaporative AC kicks on.
The elegance of the nervous and endocrine systems working in tandem is staggering. But this brings up a fundamental question of physics. We know the commands the brain sends out, but how does the physical tissue actually execute them?
Right. How does biological tissue generate and transfer heat?
Exactly. To understand the execution, we have to look at the physics of physiology. Let's start with heat production.
As we established, body heat is continually produced through three primary mechanisms. The first is the sum total of all chemical reactions associated with basic metabolic activity.
Just keeping the lights on.
Exactly. The ingestion and metabolism of food, the constant functioning of your liver, your heart beating, your brain firing neurons, your basal metabolic rate requires continuous chemical reactions.
And every single one of those reactions produces a tiny amount of heat.
Yeah, this provides the slow, steady, constant hum that maintains your baseline 37 degrees.
Okay, and the second mechanism is the skeletal muscle contraction we just discussed. Anytime you move a muscle, heat is produced. If it gets cold, the brain forces the muscles to contract involuntarily via shivering to spike heat production. What is the third mechanism?
The third is chemical thermogenesis, which is frequently referred to in clinical literature as non-shivering thermogenesis.
We touched on this when we discussed the metabolic acceleration caused by epinephrine and thyroxine.
Right, but for the exam, you need to know the exact anatomical site where this takes place. This massive, rapid spike in basal metabolic rate occurs primarily within brown and beige adipose tissue.
Brown fat. This is a fascinating evolutionary adaptation. How does brown adipose tissue differ from the standard white adipose tissue that stores excess calories?
It is structurally and functionally distinct. White adipose tissue is essentially a storage locker for lipids. Brown adipose tissue, on the other hand, is a highly specialized heat-generating organ.
And it gets its dark color because it is densely packed with mitochondria, right?
Yes, the powerhouses of the cell. And it has an exceptionally rich vascular supply. When epinephrine binds to the receptors on brown fat cells, it triggers those mitochondria to behave differently.
So instead of breaking down lipids to create ATP, which is normal cellular energy, a specific uncoupling protein inside the mitochondria essentially short-circuits the process.
Exactly. The energy is released purely as thermal heat.
So the body intentionally burns fat stores not to do mechanical work, but simply to act as an internal space heater. We will need to return to brown fat when we talk about pediatric patients, because my understanding is they rely heavily on this.
They depend on it entirely. But before we get to vulnerable populations, let's complete the physics side. We have heat production. Now, what about heat conservation? How do we hold on to the heat we've made?
Well, the primary physiological mechanism is the peripheral vasoconstriction we mentioned during the warming cascade. By tightening the blood vessels near the skin surface, the body actively shunts the warm blood away from the superficial shell and keeps it circulating deep within the core.
It essentially thickens the layer of insulation between the hot blood and the cold air. Subcutaneous fat also acts as a physical thermal barrier.
But there are behavioral actions as well, right? Things a patient does consciously or even subconsciously when they feel cold.
Behavioral thermoregulation is a massive component, adding a layer of clothing, seeking shelter from the wind, or altering body posture.
If you watch a patient in a freezing room, they will instinctively curl up into a fetal position.
Right. By pulling their arms and legs tight to their chest, they are physically reducing their body's total surface area that is exposed to the colder ambient air. They are limiting the physical landscape where heat loss can occur.
Which perfectly transitions us to the mechanisms of heat loss. The sources break down the exact physics of how thermal energy leaves the body, and it is a guaranteed exam topic.
Oh, absolutely. The terminology here is specific. You have to be able to distinguish between radiation, conduction, convection, and evaporation.
Let's define them clinically. First is radiation. This is the transfer of heat through electromagnetic waves emitting from the body's surface directly into the surrounding air.
If you hold your hand an inch away from a hot stove without touching it, you feel the heat radiating off the metal. The human body does the exact same thing.
You are constantly radiating infrared heat into the room.
Yeah, and the amount of heat a patient loses through radiation is entirely dependent on the temperature gradient, the difference between their skin temperature and the ambient room temperature. If the room is 20 degrees Celsius and the skin is 34 degrees, heat will constantly radiate outward.
So radiation requires no physical contact with an object. But the second mechanism, conduction, is entirely about direct physical contact.
Yes. Conduction is the direct transfer of heat from one physical surface to another. The fundamental rule of thermodynamics is that warmer surfaces always lose heat to cooler surfaces until they reach equilibrium.
A classic clinical example is a patient lying on a cold, stainless steel operating room table. Their body heat is actively, rapidly transferring out of their skin and directly into the metal of the table.
Exactly. Third is convection. This involves the movement of air or liquid currents. Think of convection as accelerated radiation.
Because normally your body warms the thin layer of air immediately surrounding your skin.
Right. But if you are standing in the wind or if a fan is blowing across a patient's bed, that warm insulating layer of air is constantly being mechanically stripped away and replaced by cooler air.
The body has to start over, continually losing heat to warm the new air. And crucially for nursing assessments, if a patient's skin or clothing is wet, it vastly accelerates conductive heat loss.
Because water conducts heat away from the body roughly 25 times faster than air.
Wet clothing is a massive clinical hazard. That leads us directly to the fourth mechanism, evaporation. We discussed the sympathetic nervous system triggering sweat production.
As the fluid of perspiration turns into a gas and evaporates off the skin, it pulls thermal energy away with it. but the sheer volume of fluid the body can move is staggering.
The sources note that even without actively sweating, just through invisible, insensible perspiration through the skin and lungs, the average adult loses about 600 milliliters of water a day.
Over half a liter of fluid lost every single day, just maintaining baseline thermal equilibrium.
But the extreme numbers are what really caught my attention. In severe heat, an individual can lose up to 4 liters of fluid in a single hour through evaporation.
It's unbelievable.
To visualize that, picture two massive 2-liter soda bottles. Your body has the capability to push that much fluid out of your intravascular space and through your pores in 60 minutes to keep your organs from literally cooking.
It is an astonishing physiological defense, but it highlights a massive vulnerability. Pushing 4 liters of fluid out of the bloodstream in an hour leads to profound, life-threatening hypovolemia.
The blood pressure tanks, the heart races to compensate, and if fluid and electrolytes aren't aggressively replaced, the patient will suffer cardiovascular collapse.
The cooling mechanism itself can become fatal.
Radiation, conduction, convection, and evaporation. But the sources list a fifth mechanism, and this one is often overlooked: respiration. How exactly does the simple act of breathing cause heat loss?
It is a continuous internal heat exchange. When a patient inhales ambient air, say air that is 20 degrees Celsius, it travels down the trachea, through the bronchi, and deep into the microscopic alveoli of the lungs.
And the alveolar walls are wrapped in a dense web of pulmonary microcirculation.
Right, that blood is at the core temperature of 37 degrees. The pulmonary blood instantly transfers its heat to the inhaled air, warming it to body temperature and fully humidifying it. Then the patient exhales.
They literally breathe out their core heat. This makes perfect sense when you look at clinical vital signs. This is why a patient's respiratory rate naturally elevates when they have a fever.
Yes. The body recognizes it is too hot, and it tries to rapidly blow off excess internal thermal energy. It is the human equivalent of a dog panting.
And the inverse is equally true. When you assess a patient suffering from severe hypothermia, you will see profoundly depressed respiratory rates.
The brain is trying to conserve every microscopic fraction of thermal energy it has left, so it actively slows down the respiratory drive to stop venting warm air out of the lungs. Every vital sign is a clue to the underlying metabolic state.
It is a complete physiological symphony. But so far, we have been talking about a healthy adult system functioning perfectly. We need to shift our focus to what happens when the hardware isn't fully installed yet, or when it is beginning to wear out.
Right. The extremes of age are a major focus for clinical exams because they represent our most vulnerable patient populations.
Let's look at the pediatric side first. Why are newborns and premature infants at such an extreme disadvantage when it comes to thermoregulation?
You can effectively conceptualize a newborn as having almost zero inherent heat-conserving capacity. They are battling several massive anatomical and physiological disadvantages simultaneously.
First, and most importantly, is their body surface area-to-weight ratio.
Yes. Compared to their tiny overall mass, they have a massive amount of skin exposed to the environment. They have a huge surface area through which to lose heat, but very little mass to generate it.
Second, they possess incredibly thin layers of subcutaneous fat, meaning they have almost zero natural thermal insulation.
And third, their blood vessels are anatomically located very close to the skin surface, making it exceptionally easy for ambient cold to draw heat right out of their circulating blood.
So they are structurally designed to lose heat rapidly. But earlier we talked about the shivering response. If a newborn is cold, don't they just shiver to generate heat?
They do not. This is a critical point for pediatric nursing. Newborns generally lack the muscular development and neurological maturity to initiate the shivering response. They cannot mechanically vibrate their muscles to generate heat.
If they can't shiver and they have no insulation, how do they survive a drop in temperature? What is their defense mechanism?
They rely entirely on their internal chemistry. They depend almost exclusively on non-shivering thermogenesis.
Oh, back to the brown fat.
Exactly. Infants are born with a unique, abundant supply of that highly metabolically active brown adipose tissue we discussed earlier, located primarily around their neck, thorax, and kidneys.
When skin sensors detect cold, the sympathetic nervous system triggers this brown fat. The mitochondria immediately uncouple, drastically increasing the infant's metabolic rate and oxygen consumption to generate internal heat.
So a cold newborn is burning through massive amounts of oxygen and cellular energy just to maintain their core temperature.
Precisely. This is why cold stress in a neonate is so dangerous. It rapidly leads to hypoxia, depletion of oxygen, and hypoglycemia because they are burning through all their glucose reserves just to stay warm.
Their only physical defense mechanism is a behavioral one. They naturally adopt a flexed, curled-up posture to reduce that massive surface area exposure.
That is a profound clinical insight. A cold baby isn't just uncomfortable, they are actively depleting their vital metabolic resources. Now let's look at the other end of the age spectrum, older adults.
With infants, the system is underdeveloped. With the elderly, the system is wearing out.
What specific physiological changes compromise an older adult's ability to thermoregulate?
It is a systemic degradation of the feedback loops. As we age, peripheral circulation slows down. The blood vessels lose their elasticity and their brisk vasoconstrictor response.
When an elderly patient steps into a cold room, their vessels cannot slam shut quickly or effectively enough to keep the warm blood in the core, so they lose heat to the environment.
Furthermore, the skin's thermoregulatory capacity diminishes. The eccrine sweat glands atrophy, leading to significantly reduced or sometimes completely absent sweating in high heat.
So they can't conserve heat well in the cold, and they can't dump heat well in the hot weather because the evaporative AC is broken.
Exactly. Add to that the fact that their basal metabolic rate naturally slows down with age, meaning their internal furnace simply isn't generating as much baseline heat to begin with.
Their skeletal muscle mass decreases, which weakens the shivering response, but perhaps the most insidious and dangerous change of all is neurological.
The fading sensors.
Yes. The peripheral thermoreceptors embedded in their skin, the sensor sending data back to the hypothalamus, they begin to fail.
Older adults experience a markedly reduced perception of environmental temperature. They simply do not feel the biting cold or the sweltering heat as acutely as a younger person does. The alarms in the smart home have stopped working.
This raises an important question. If an elderly patient doesn't feel the heat in their unair-conditioned apartment in August, they aren't going to get up and turn on a fan or drink a glass of ice water.
And if a newborn physically cannot shiver and has no insulation to retain heat, they can't ask for a blanket.
As a nurse, you are not just treating these patients, you are acting as their external sensors and their manual thermostat.
You have to anticipate their thermal needs based entirely on the environment and your clinical knowledge, because you cannot rely on them to exhibit signs of distress. By the time an elderly person complains of heat exhaustion or a newborn shows signs of cold stress, their physiological reserves are already severely, dangerously depleted.
We have established the normal physiological baseline and the vulnerable extremes. Now we need to cross the line into pathology. Understanding the distinct fundamental differences between fever, hyperthermia, and hypothermia is absolutely critical for clinical judgment.
These terms are often used interchangeably in casual conversation, but medically they represent entirely different mechanisms.
Let's start with fever. What exactly is a fever?
Fever is arguably the most common exemplar of altered thermoregulation you will encounter in clinical practice. The most crucial concept to grasp about a fever is that it's not a failure of the system. It is an intentional, highly coordinated immune response.
In a fever, the hypothalamic set point, that target of 37 degrees Celsius, is actively raised by the brain. The body decides it needs to be hotter.
The thermostat gets manually cranked up. It isn't that the body is accidentally getting hot because it can't cool down. It is that the new definition of normal is suddenly 39 degrees.
Exactly. And you must know the biochemical mechanism for the exam. It is driven by pyrogens, which are fever-producing substances. There are two categories, exogenous and endogenous.
Exogenous pyrogens originate from outside the body. Think of bacterial endotoxins, viruses, or fungal infections. When these exogenous pyrogens invade the bloodstream, they trigger the immune system.
The body's defense forces recognize the invader.
Yes, your phagocytic white blood cells, the macrophages, engulf the bacteria. In response, these white blood cells secrete endogenous pyrogens.
These are chemical messengers produced internally as part of the immune response. They include specific cytokine proteins like interleukin-1, interleukin-6, tumor necrosis factor, and interferon.
Okay, let's trace this. Outside bacteria, the exogenous pyrogen causes the white blood cells to release immune proteins, the endogenous pyrogens. What do those internal proteins do?
Those endogenous pyrogens travel through the bloodstream, cross the blood-brain barrier, and reach the hypothalamus. There, they trigger the production of a specific lipid called prostaglandin E2.
It is prostaglandin E2 that acts directly on the thermoregulatory center of the hypothalamus, physically elevating that thermal set point.
So prostaglandin E2 rewires the thermostat.
It does. Suddenly, the hypothalamus looks at the core temperature of 37 degrees and registers it as dangerously cold compared to the new set point of 39 degrees.
So what does it do? It initiates the entire warming cascade we discussed earlier.
It triggers massive vasoconstriction, which is why feverish patients look pale, and it triggers intense shivering, which are the classic chills and rigors associated with a spiking fever.
The body will forcefully generate heat until the core temperature reaches the new, higher set point. The evolutionary thought process here is that this elevated temperature inhibits bacterial replication and enhances white blood cell function.
The pathway is exogenous pyrogens trigger endogenous pyrogens, which trigger prostaglandin E2, which elevates the set point. That is a perfect exam sequence. Now, how does that differ from hyperthermia? Because on the surface, a hyperthermic patient and a feverish patient both just have high body temperatures.
Here's where it gets really interesting. The clinical presentation might look similar, but the pathophysiology of hyperthermia is fundamentally different. In hyperthermia, the body temperature rises dangerously above 37.6 degrees Celsius, but the hypothalamic set point is entirely unchanged.
The thermostat in the brain is still desperately aiming for 37 degrees.
It is the broken air conditioning scenario. The thermostat on the wall says 70 degrees, but the sun is beating through the windows, the furnace is stuck in the on position, and the AC unit is broken, so the house climbs to 90 degrees against its will.
That is the exact mechanism. Hyperthermia occurs when the body's natural ability to dissipate heat is interrupted, or when heat production vastly exceeds the capacity of the cooling mechanisms. The set point hasn't moved, the physical machinery has simply been overwhelmed or destroyed.
What causes the machinery to fail?
It can be driven by the environment prolonged exposure to high temperature and high humidity, which nullifies evaporative cooling. It can be caused by excessive physical exertion, like running a marathon in hot weather without adequate fluid replacement.
It can be triggered by metabolic diseases like hyperthyroidism, which locks the internal furnace in overdrive.
It can even be the result of a physical traumatic brain injury to the hypothalamus itself, rendering the control center blind, or the result of certain pharmacologic agents that suppress sweating.
So fever, the set point is intentionally raised, hyperthermia. The set point is normal, but the cooling mechanisms are overwhelmed. That distinction completely changes how a nurse should approach treatment, which we will get to. Let's swing to the opposite extreme of the spectrum, hypothermia.
Hypothermia is clinically defined as a core body temperature declining below 36.2 degrees Celsius. For nursing exams, you are generally required to know the clinical classifications of severity based on temperature ranges.
Mild hypothermia is defined as a core temperature between 34 and 36 degrees Celsius, or roughly 93.2 to 96.8 Fahrenheit.
Moderate hypothermia falls between 30 and 34 degrees Celsius, and severe hypothermia is classified as any core temperature dropping below 30 degrees Celsius or below 86 degrees Fahrenheit.
Below 30 Celsius is severe. Now, clinically, we almost always associate hypothermia with accidental trauma. A hiker gets lost in a blizzard, someone falls through the ice into a frozen lake, or an unhoused individual lacks adequate winter clothing.
But the sources point out that hypothermia isn't universally a pathological disaster. There is a deeply fascinating clinical application known as therapeutic hypothermia,
Why would a medical team intentionally freeze a patient?
also referred to as targeted temperature management. Therapeutic hypothermia is intentionally induced in a highly controlled critical care setting, usually the intensive care unit. Accidental hypothermia is dangerous precisely because it is uncontrolled and unsupported. Therapeutic hypothermia is used as a neuroprotective strategy to preserve brain tissue after a severe ischemic event, most commonly following a cardiac arrest.
To understand the cure, we have to understand the injury. What happens during cardiac arrest that requires cooling?
When a patient's heart stops beating, systemic circulation ceases immediately. Oxygen is completely cut off from the brain and vital organs. When paramedics or the code team restore the heartbeat, when circulation returns, the sudden, massive rush of oxygenated blood back into the oxygen-starved tissues actually causes catastrophic secondary damage.
This is known as reperfusion injury. The sudden influx of oxygen creates a burst of free radicals and triggers massive cellular inflammation.
So the blood returning to the brain actually causes the brain to swell and damage itself. How does lowering the core temperature prevent that?
By intentionally cooling the patient's core temperature down to around 32 to 34 degrees Celsius, we drastically slow down their cerebral cellular metabolism. We are essentially placing the brain into a state of highly controlled hibernation.
Lowering the metabolic demand.
Precisely. Therapeutic hypothermia counteracts the toxic overstimulation of neural cells. At a microscopic level, it stabilizes the release of excitatory neurotransmitters like glutamate, and it prevents the massive intracellular influx of calcium.
If left unchecked, that calcium influx triggers a cascade of enzymes that literally digest the cell from the inside out.
By cooling the brain, we halt that destructive chemical cascade, prevent cerebral edema, and buy the neurological tissue time to heal with a vastly reduced demand for oxygen.
It is mind-blowing. The body's extreme sensitivity to temperature drops is usually its greatest vulnerability, but in the ICU, we weaponize that vulnerability to save the brain. However, when hypothermia or hyperthermia happens out in the wild, uncontrolled, it triggers a catastrophic sequence of systemic failures.
This leads us directly into the fatal cascades. We need to trace the physiological domino effect. When a patient is hyperthermic, how does an elevated body temperature actually cause death? What breaks first?
It is a terrifying, rapid sequence of cardiovascular collapse. Let's walk through it step by step. Let's take a patient suffering from severe environmental hypothermia heat stroke.
The sustained, significant increase in core body temperature prompts the hypothalamus to deploy its ultimate cooling defense. Massive, sustained sweating and profound peripheral vasodilation.
The body opens all the blood vessels in the skin and dumps fluid through the pores, trying to utilize evaporative cooling.
Exactly. But if this excessive sweating is coupled with a sustained high core temperature and no external fluid replacement, the patient rapidly experiences massive sodium and water loss. They become profoundly dehydrated.
They're sweating out their blood plasma.
Essentially, yes. That massive fluid loss means the overall volume of blood circulating in the vascular system drops significantly. This state of hypovolemia leads directly to hypotension, a dangerous, precipitous drop in blood pressure.
So the pipes are suddenly half empty, and the pressure plummets. How does the heart respond to that?
The bearer sisters in the arteries sense this massive drop in pressure, and the heart tries to compensate the only way it knows how, by beating much faster to circulate whatever volume is left. This leads to severe tachycardia.
But because the actual volume of blood is so depleted, the heart is basically pumping empty. Cardiac output, the amount of blood actually reaching the organs, inevitably drops.
Low pressure, a racing heart, and failing delivery.
It gets worse. Because so much water has been lost through sweating, the remaining blood becomes incredibly thick and viscous. This thick blood cannot easily navigate the microcirculation, the tiny capillary beds in the organs.
The reduced perfusion, combined with the extreme internal heat, causes the blood to begin sludging and coagulating. Tiny microthrombi or blood clots start forming throughout the microvasculature.
The plumbing of the entire body is clotting up while the main pump is failing. What is the terminal stage of this cascade?
Total irreversible cardiovascular collapse. The sustained high core temperature combined with the absolute lack of oxygenated blood flow leads directly to cerebral edema, massive swelling of the brain tissue.
This causes rapid central nervous system degeneration, progressing from delirium to seizures to coma. Simultaneously, the lack of perfusion to the kidneys causes acute renal necrosis. The renal tissue dies.
It is a complete multi-organ failure driven entirely by the loss of fluid used in a desperate attempt to cool down. Sweating leads to hypovolemia. Hypovolemia leads to hypotension and tachycardia, which drops cardiac output, which causes microcoagulation, leading to brain swelling and kidney death.
That is a brutal cascade. Let's look at the opposite extreme. Walk us through the hypothermia cascade. What is the downward physiological spiral of the cold?
The hypothermia cascade is equally fatal, but the mechanism of failure is entirely different. As a patient's core temperature begins to drop, the initial compensatory mechanisms violently kick in: intense shivering to generate metabolic heat, and profound peripheral vasoconstriction to conserve it. The blood vessels in the arms, legs, and skin clamp down incredibly tight,
Shunting all the warm blood to the core to protect the heart and lungs.
Yes, but here is the critical flaw in that defense. Prolonged, intense vasoconstriction completely cuts off the oxygenated blood flow to the skin and peripheral tissues. If this is maintained for too long, it leads to peripheral tissue ischemia, cellular death from lack of oxygen. This is the physiological basis of frostbite.
The body is willing to sacrifice the fingers and toes to keep the heart beating.
It is. However, the tissue in the extremities has a failsafe. To prevent complete necrosis, the local blood vessels will occasionally dilate briefly to allow intermittent reperfusion, a small splash of blood to keep the tissue barely alive.
But every single time the body allows that reperfusion, it sends freezing cold, acidic, unoxygenated blood from the extremities rushing right back into the central core, which drops the core temperature even further.
It is a terrible catch-22. Save the hand, freeze the heart.
As the core temperature continues to plummet, the physical properties of the blood change. Just like in hyperthermia, the blood becomes highly viscous, but this time it is acting like cold syrup.
This increased viscosity leads to drastically reduced flow and, again, uncontrolled coagulation within the microcirculation.
The blood gets too thick to pump effectively. When does this reach the point of no return?
The true turning point occurs when the hypothalamus finally exhausts its energetic resources. The intense vasoconstrictive tone, which is being desperately maintained by the sympathetic nervous system, eventually fails. The smooth muscle in the blood vessels runs out of ATP.
When that sympathetic tone is lost, you get sudden, massive, uncontrolled vasodilation. All of those peripheral blood vessels that were clamped completely shut suddenly spring wide open.
Oh no, so whatever remaining warm blood is left in the core instantly rushes out to the freezing skin surface.
Exactly. It dramatically, lethally accelerates the total loss of body heat into the environment. But this massive rush of warm core blood to the skin creates a terrifying and tragic behavioral phenomenon. It creates a sudden, intense, false warming sensation for the victim.
You have to remember, at this stage, the patient's brain is severely hypoxic, and their cognition is practically non-existent due to the thick blood and depressed cardiac output. Their altered mental state severely misinterprets this sudden skin flush.
They feel like they are burning up. This is paradoxical undressing.
Yes. Individuals in the profound late stages of severe hypothermia have been documented repeatedly actually stripping off their winter clothing right before they suffer cardiovascular collapse and slip into a coma. Their failing brain tells them they are overheating, when in reality they are minutes away from total cardiac arrest.
The tragic, awful irony of tearing off your winter coat while you freeze to death in the snow. From a clinical perspective, if an EMT or an ER nurse receives a patient from a freezing environment who has inexplicably removed their clothes, they must recognize that this is not just strange behavior. It is the absolute final, fatal stage of severe hypothermia. The hypothalamus has surrendered.
It is the ultimate clinical indicator of impending cardiovascular collapse. To prevent these fatal cascades from ever reaching that point of no return, a clinician has to anticipate who is most likely to experience them.
We need to review the specific risk factors: demographics, behavioral choices, underlying illnesses, and genetics. Let's look at the data. Who is most vulnerable?
The demographic data, largely compiled by the Centers for Disease Control and Prevention, points to stark and significant health disparities. The most vulnerable populations are heavily influenced by socioeconomic and racial factors.
The CDC reports that non-Hispanic Black individuals have a heat-related mortality rate that is 2.5 times higher than that of non-Hispanic whites. Similarly, they suffer a cold-related mortality rate that is 2.0 times higher.
2.5 times higher for heat mortality, double the risk for cold mortality. What drives that immense disparity?
It is heavily tied to socioeconomic status and environmental exposure. People of lower socioeconomic status often lack the resources for adequate shelter, reliable heating in the winter, air conditioning in the summer, and weather-appropriate clothing.
The unhoused population is incredibly, tragically vulnerable. They are constantly exposed to the extreme elements without any safe haven to regulate their ambient temperature.
Geography also plays a significant role. Heat-related deaths naturally cluster in the southern and western United States, while western states also record the highest cold-related death rates due to expansive, extreme mountainous environments and rural isolation.
It is a harsh reminder that healthcare doesn't just happen inside the pristine walls of a hospital. A patient's survival is deeply tied to their social determinants of health before they ever hit the emergency room doors.
Now, let's look at behavioral risks. Specifically, impaired cognition due to substance use. I want to highlight what we can call the alcohol paradox. A classic pop culture trope is the St. Bernard rescue dog bounding through the alpine snow, carrying a little wooden barrel of whiskey around its neck to warm up a stranded, freezing hiker.
But biologically, giving alcohol to someone in the cold is a catastrophic idea, isn't it?
It is a potentially fatal clinical mistake. People under the influence of drugs or alcohol are already at a baseline risk simply because their sensory alterations impair their judgment. A heavily intoxicated person might not realize how dangerously cold they are, or they might lose consciousness in a snowbank.
But alcohol itself is a direct, potent peripheral vasodilator.
It artificially forces the blood vessels to open up.
Exactly. It forces the peripheral blood vessels near the skin to dilate, overriding the hypothalamus's desperate attempts to vasoconstrict. This rushes warm core blood to the skin surface. So the freezing person takes a shot of whiskey, their face flushes, and they say, "Ah, I feel so much warmer."
They feel warmer because their skin thermoreceptors are suddenly flooded with warm blood. But what is actually happening physically?
They are completely compromising their core. They are venting all of their deep internal heat straight out into the freezing air through massive radiation and convection.
Precisely. They are rapidly accelerating their heat loss and dropping their core temperature dangerously close to the fatal cascade, while simultaneously impairing their brain's ability to recognize the danger. Because alcohol acts as a vasodilator, it is one of the most common underlying physiological factors in accidental hypothermic deaths.
The alcohol paradox. It makes you feel toasty warm while actively helping you freeze to death. What about underlying health conditions? Who is walking into the hospital or clinic already at a physiological disadvantage for thermoregulation?
Any chronic condition that reduces the body's ability to generate metabolic heat, manage fluid volume, or constrict blood vessels puts a patient at immense risk. Congestive heart failure is a major one because the central pump is already wet. It cannot handle the tachycardic demands of extreme heat or cold.
Diabetes is a massive risk factor due to underlying microvascular damage and peripheral neuropathy. A diabetic patient literally might not feel the extreme cold in their feet, leading to severe frostbite before they even realize they are in danger.
What about surgical patients? You mentioned the OR table earlier.
Surgical procedures are a profound risk. Patients are often exposed, naked or lightly draped, on cold, stainless steel operating tables in heavily air-conditioned rooms for hours. Furthermore, general anesthesia completely abolishes their central thermoregulatory defenses.
They cannot shiver, and their blood vessels cannot constrict. They are entirely reliant on the surgical team to manage their temperature artificially.
And traumatic injuries to the brain itself.
Yes, traumatic brain injury, stroke, or intracranial neoplasms. If the physical area of the brain that is damaged by trauma or a tumor includes the diencephalon and the hypothalamus, the master thermostat is physically broken.
The patient completely loses central control and becomes poikilothermic, meaning their body temperature simply mimics the temperature of the room they are in.
We have covered demographics, behaviors, and chronic illnesses, but the clinical sources highlight one extremely specific, highly tested genetic risk factor, the genetic wildcard, malignant hyperthermia. What exactly is MH, and why is it such a critical exam topic?
Malignant hyperthermia, or MH, is a rare but absolutely critical, life-threatening surgical complication. It is a biochemical chain reaction, and it is triggered entirely by exposure to specific, commonly used pharmacological agents in the operating room, volatile inhalation anesthetics, and a specific depolarizing muscle relaxant called succinylcholine.
Succinylcholine. That is a word to highlight in the notes.
It is an inherited condition with an autosomal dominant pattern. If a patient with this specific genetic mutation is given these triggering anesthetic agents, it sparks a massive, severe hypermetabolic state within their skeletal muscles.
The drugs cause a defect in the sarcoplasmic reticulum of the muscle cells, causing intracellular calcium levels to skyrocket out of control.
And what does massive calcium influx do to a muscle?
It causes the muscles to contract continuously and rigidly. This unrelenting, massive skeletal muscle contraction burns through ATP at an astonishing rate, generating a lethal amount of metabolic heat incredibly fast. The patient's core temperature can rise 1 to 2 degrees Celsius every 5 minutes.
So it isn't the environment making them hot, and it isn't a fever from an infection. Their own skeletal muscles are chemically forced to turn into an uncontrolled runaway furnace because of the anesthetic drug.
Exactly. It is a true, terrifying medical emergency in the operating room. Epidemiologically, it complicates about 1 in 100,000 surgeries in adults, and is more common in children, affecting about 1 in 30,000 pediatric surgeries.
Because it is an autosomal dominant inherited trait, taking a thorough, detailed family history before any surgical procedure is absolutely vital. If a patient mentions that their uncle had a severe, unexplained high fever and muscle rigidity during a routine surgery 20 years ago, that is a massive red flag that must be investigated before they ever receive anesthesia.
We have covered the theory, the pathophysiology, and the risks. Let's move from the textbook to the bedside. How does a nurse actually assess these conditions in real time? Let's start with the most basic clinical act, taking the temperature. Where and how are we measuring this? Keeping in mind we are hunting for that core temperature.
The clinical sources state unequivocally that the most reliable, accurate, and continuous measurement of true core body temperature is obtained via a pulmonary artery catheter.
A catheter threaded directly into the pulmonary artery inside the heart?
Yes, it measures the temperature of the blood returning directly from the core organs right before it hits the lungs. But obviously, that is highly invasive and is strictly reserved for intense critical care settings, like the ICU or major cardiac surgery.
Outside of critical care on a standard medical surgical floor, the most common and reliable way to measure core body temperature is the rectal route. And for the nursing exam, you must memorize the exact, safe insertion depths.
Precision is key here. What are the numbers?
A lubricated thermometer probe is inserted into the rectal canal at a depth of exactly 1 to 1.5 inches in an adult patient. For a pediatric patient, a child, the depth is much shallower, 0.5 to 1 inch. Inserting further risks perforating the bowel.
1 to 1.5 inches for adults, zero point 0.5 to 1 inch for children. Memorize those numbers. What about the other routes we see every day? Oral, axillary temporal.
You will see tympanic measuring infrared heat from the tympanic membrane in the ear. You will see oral, under the tongue, which is reliable if the patient hasn't just drank a hot or cold liquid. Axillary in the armpit is common but reflects shell temperature more than core temperature, so it is consistently lower.
And you'll see the temporal artery scanner swiped across the forehead. But note the specific, highly tested caveat. The temporal artery method is considered unreliable and should generally be avoided in children younger than 2 years of age.
Let's pause on that. Why is temporal unreliable in a toddler?
It comes down to anatomy and evaporative physics. In infants and toddlers under 2, their head makes up a disproportionately massive amount of their total body surface area. Furthermore, the depth of the temporal artery and the thickness of the skull are still developing.
Because they lose so much heat from their head, and because they can be highly diaphoretic sweaty on their forehead when distressed, the rapid evaporative cooling of the skin heavily skews the scanner. It might read a normal skin temp, while the child's internal core is actually spiking a severe fever.
That makes perfect physiological sense. The surface evaporation masks the internal furnace. Okay, so you have your temperature reading, but a good clinician assesses the whole patient, not just the digital readout on the thermometer. What are the physical head-to-toe findings you're looking for? Let's start with a hyperthermic patient.
The clinical presentation of a hyperthermic patient depends heavily on why they are hot and what stage of the cascade they are in. But generally, because of the massive peripheral vasodilation, as the body tries to dump heat through the skin, the patient will appear deeply flushed, and their skin will feel very warm or hot to the touch.
Red and hot. The windows are open.
Yes. Now, if their physiological cooling mechanisms are still intact and trying to work, they will be heavily diaphoretic, sweating profusely. You will see drenched clothing and sheets. But, and this is a critical emergency indicator, if they have progressed to severe heat stroke, meaning they have completely depleted their intravascular fluid volume and their eccrine sweat glands have simply failed from exhaustion, they will present with shockingly dry skin and parched mucous membranes.
A patient who is core hot but bone dry on the surface is in imminent, life-threatening danger, because that means the evaporative AC is completely out of coolant. The only defense mechanism left is broken.
Exactly. Systemically, you will also see drastically decreased urinary output as the kidneys clamp down to hoard whatever water is left. And neurologically, because the extreme heat denatures proteins in the central nervous system, they will exhibit altered mental status.
This begins as irritability and slight confusion, progressing rapidly to severe delirium, visual hallucinations, full-body seizures, and ultimately coma.
Red, hot, progressively dry, confused, anuric, and seizing. What about the physical findings for the other extreme? How does a hypothermic patient present?
For hypothermia, your physical assessment is observing the results of intense peripheral vasoconstriction. The skin will feel ice cold to the touch and will appear starkly pale or cyanotic. Cyanosis is a bluish or grayish tint to the skin and lips, indicating a profound lack of oxygenated blood in the superficial capillaries.
When you press firmly on their fingernail bed to blanch it, the capillary refill time will be significantly prolonged, much longer than the normal 2 seconds. You'll initially observe severe muscle rigidity and violent shivering.
But wait, earlier you mentioned that the shivering response eventually exhausts itself. When exactly does that happen?
This is a crucial exam threshold. The shivering response dramatically diminishes and entirely ceases when the core body temperature decreases to exactly 30 degrees Celsius, or 86 degrees Fahrenheit.
So if EMS brings in a patient pulled from a frozen river and they were shivering violently in the ambulance, but suddenly they stop shivering in the trauma bay and they haven't been actively warmed yet, that is not a sign of improvement.
It is a catastrophic sign.
Yeah.
It means their skeletal muscles have completely depleted their glycogen stores, their neurological drive has been suppressed by the cold, and their core temperature has crossed the threshold into severe, life-threatening hypothermia below 30 Celsius.
Neurologically, the descent is steady. At 34 degrees Celsius, they will exhibit poor physical coordination, ataxia, and sluggish, confused thoughts. By 30 degrees, when the shivering stops, this altered mental state progresses to profound stupor and coma.
And what is happening to the heart at 30 degrees Celsius?
From a cardiac electrophysiology perspective, a cold heart is a highly irritable, unstable heart. The cold disrupts the sodium and potassium ion channels in the myocardial cells. You will frequently see dangerous, chaotic dysrhythmias on the EKG monitor, specifically atrial fibrillation and, most lethally, ventricular fibrillation.
The heart stops acting as a coordinated pump and just starts quivering uselessly. Okay, we have our assessment. We understand the pathophysiology. The final step for the exam is action. What are the specific clinical management strategies and collaborative interventions the nurse will implement to save these patients? Let's start with primary prevention. How do we stop this before it starts?
Primary prevention relies entirely on environmental control and proactive patient education. For adults, it is ensuring vulnerable patients have access to optimal ambient temperatures, educating them to use fans, open windows, and seek shade in the summer, and utilizing adequate blanketing and blocking drafts in the winter.
It involves social work and community outreach, directing unhoused populations to cooling centers or heated shelters during extreme weather events.
Now we have to circle back to clothing selection. We established that evaporative and convective heat loss is vastly multiplied when clothing is wet.
Yes, wet clothing increases heat loss by roughly a factor of 5. Getting a patient out of wet clothes immediately is the paramount first step in any cold weather rescue. And that principle brings us right back to the delivery room with our pediatric patients. A newborn infant is born covered in warm amniotic fluid.
They emerge wet into a brightly lit, heavily air-conditioned, cool delivery room. They have a massive surface area and zero fat insulation. They are prime, immediate targets for rapid evaporative and radiant heat loss.
So what is the immediate nursing intervention the second that baby is delivered?
You must dry the infant vigorously and immediately with warm towels. Remove the wet towels, wrap them in fresh, dry blankets, and immediately put a knit cap on their head because their large head is a massive source of radiant heat loss. From there, placing the infant skin to skin against the mother's bare chest, covered by a blanket, uses the mother's robust thermoregulation to warm the child.
If skin to skin isn't possible, the infant must be placed immediately under a mechanical radiant warmer.
Dry them, cover the massive surface area of the head, and utilize maternal conduction or artificial radiation.
Excellent. Now, moving to the adult center. What if primary prevention failed and we have a patient admitted with a dangerously elevated temperature? How do we physically cool them down? First, strip away any environmental barriers. Remove excess blanketing and heavy clothing. Initiate aggressive intravenous hydration to replace the massive fluid loss from sweating and to support blood pressure. Then, we utilize active external cooling measures. We place specially designed cool packs in the axillary regions, the armpits, and the groin.
Why specifically the armpits and the groin?
Because those areas house massive superficial blood vessels, the axillary and femoral arteries and veins. By applying cold directly over these major vascular highways, we are actively cooling the blood as it circulates back into the core. We can also utilize circulating cooling blankets or lukewarm sponge baths.
But there is a massive physiological warning here, right? A line you cannot cross when cooling a patient.
It is a delicate balance. Care must be taken not to induce shivering. If you cool a hyperthermic patient too aggressively or with water that is too cold, their peripheral thermoreceptors will panic and tell the hypothalamus they're suddenly freezing. The brain will initiate violent shivering.
Those rapid muscle contractions will generate massive amounts of internal metabolic heat, completely counteracting your external cooling efforts and burning up the patient's remaining oxygen reserves.
So you cool them, but you don't freeze them into a counterproductive shiver. What if the hyperthermia is incredibly severe, like a core temp of 41 degrees Celsius?
For severe refractory hyperthermia, collaborative medical interventions include aggressive internal core cooling. This involves procedures like gastric or colonic lavage, We insert a tube and literally flush their stomach or colon with chilled, sterile saline, using the massive surface area of their internal organs to draw heat directly out of the core from the inside.
What if the elevated temperature isn't environmental hyperthermia, but rather a severe fever driven by an infection? Because we established those are pathophysiologically different.
If it is a mild to moderate fever, it generally does little systemic harm and is actually beneficial for enhancing the immune response against the pathogen. But if the fever is dangerously high, causing extreme metabolic demand, tachycardia, or severe discomfort, we use antipyretics. These are medications that act on the hypothalamus to lower the artificially elevated set point.
This primarily includes NSAIDs, like ibuprofen or naproxen, and acetaminophen.
What about aspirin? Aspirin is a classic fever reducer.
Aspirin is effective for adults, but here's an absolute non-negotiable rule for pediatric nursing that will be on your exam. Aspirin is never recommended for children or teenagers presenting with a viral illness
Let's dig into the why on that. Why is aspirin dangerous for a kid with a fever?
because of the severe documented risk of Rey syndrome. Rey syndrome is a rare but catastrophic, life-threatening condition that causes acute mitochondrial injury. It leads to massive swelling and fat accumulation in the liver and severe encephalopathy swelling of the brain. The exact mechanism isn't perfectly understood, but the epidemiological link between viral fevers, aspirin use in children, and the onset of Rey syndrome is undeniable. So pediatric fevers are managed with acetaminophen or ibuprofen, never aspirin.
No aspirin for kids due to Rey syndrome. Understood. Now, what about our genetic wild card, the malignant hyperthermia patient whose muscles are burning up on the operating room table because of succinylcholine? How do you stop that chemical chain reaction?
You cannot cool them externally fast enough to save them. You must stop the reaction at the cellular level. We use a highly specific, life-saving intravenous drug called dantrolene sodium. Dantrolene directly counteracts the genetic abnormality. It works inside the skeletal muscle cells to block the release of calcium from the sarcoplasmic reticulum.
It dramatically reduces the intracellular calcium levels, which immediately forces the rigid muscle fibers to relax and definitively shuts down the runaway hypermetabolism. The rapid administration of dantrolene has dramatically reduced the historical mortality rate of MH.
Dantrolene fixes the calcium leak and saves the day. Okay, finally, let's flip the script to managing hypothermia. A patient is pulled from a snowbank and brought into the ER freezing cold. We obviously need to warm them up. But the clinical sources place a massive emphasis on the danger of rewarming. It is not as simple as throwing them in a hot shower. Let's break down the staged methods of rewarming first.
If the hypothermia is classified as mild core temp between 34 and 36 degrees Celsius, we rely on passive external rewarming. This simply means we remove them from the cold environment, strip off any wet clothing, provide dry blankets and warm ambient room air, offer warm oral liquids if they are fully conscious, and encourage physical movement. We are essentially stopping the heat loss and relying entirely on the patient's own intact internal metabolic furnace to slowly bring their temperature back up.
Passive external, letting their body do the work. What if they are moderate and their own furnace isn't enough?
Then we escalate to active external rewarming. This is when the medical team actively applies artificial heat to the outside of the patient's body. We use forced air warming blankets like a bear hugger electric heating pads or radiant heat lamps.
What about warmed 5E fluids?
We absolutely use heated intravenous fluids, but the clinical sources specify a volume caveat. Warmed 5E fluids are typically only beneficial for altering core temperature if the patient is receiving a massive volume, generally greater than 500 milliliters rapidly. Small pushes of warm fluid lose their heat too quickly in the tubing.
So passive external, then active external. What if they are in the severe category, below 30 degrees Celsius, unconscious, rigid, and barely breathing?
At that profound level of hypothermia, external warming is dangerously insufficient. We must utilize active core rewarming. This means applying aggressive thermal heat directly to the internal organs. We do this through the continuous rapid infusion of highly warmed IV solutions, the administration of heated and humidified oxygen through an endotracheal tube directly into the lungs, and just like we use cold fluids for hyperthermia, we perform continuous warm fluid lavage of the gastric cavity, the bladder, or the peritoneal cavity.
In the most extreme, desperate cases of cardiac arrest due to hypothermia, we might initiate extracorporeal membrane oxygenation, or ECMO. We literally drain their blood out of their body, run it through a machine that warms and oxygenates it, and pump it back into their core.
That is the ultimate technological override of the physiological system. But this brings us to the most critical warning in the sources. Why is the rewarming process itself so incredibly dangerous? Why can't we just pack a severely hypothermic patient in hot water bottles from head to toe and crank up the heat as fast as possible?
If we connect this to the bigger picture, it's because of the vascular plumbing and the vulnerability of the heart. We established earlier that a cold heart is an irritable heart, highly prone to lethal dysrhythmias like ventricular fibrillation. If you violently and rapidly apply heat to the outside of a patient's body, the arms and legs, before the core is warm, you cause sudden massive vasodilation in those extremities.
The frozen blood vessels in the arms and legs spring open.
Yes. And what is sitting inside those extremities? Cold, stagnant, highly acidic, unoxygenated blood full of metabolic waste products. When those vessels dilate, that toxic freezing blood rushes straight back through the venous system and dumps directly into that highly irritable, fragile, cold heart.
The rush of cold acid hits the irritable heart muscle.
And it instantly triggers a fatal cardiac arrest. This physiological phenomenon is known as core temperature after drop, or rewarming shock. The peripheral return drops the core temperature even further just as you were trying to save them. Therefore, core rewarming is a meticulous, high-stakes procedure. It requires continuous, unbroken cardiac monitoring and constant core body temperature observation via that rectal or esophageal probe. You must intentionally warm the central core organs before or concurrently with the periphery. You have to stabilize the heart before you open the floodgates of the extremities.
Warm the core first, monitor the rhythm constantly, and respect the fragility of the frozen myocardium. This brings us to the end of our sources. We have mapped the entire system. We started with the master thermostat and hypothalamus, traced the hormonal and neural cascades, explored the literal physics of how heat leaves the skin, examined the profound vulnerabilities of the very young and the very old, differentiated the pathologies of fever versus failure, and walked step by step through the clinical management of a body that is either boiling over or freezing solid. So what does this all mean?
It means thermoregulation is clearly not just about charting a number. It is about visualizing this intricate, desperate, continuous dance between the brain, the endocrine glands, the vascular plumbing, the muscle tissue, and the brutal physics of the environment.
It is about recognizing that every single clinical symptom you see, from a premature infant's sudden respiratory distress, to an elderly patient's subtle confusion in a hot room, to a trauma patient's sudden chaotic cardiac arrhythmia on the monitor, could be fundamentally rooted in the body's exhausting battle to maintain that tiny 1.5-degree window of survival. Mastering the why behind these cascades means the difference between catching a subtle physiological shift early and responding to a fatal code blue.
You are the external sensors. You are the manual thermostat. Your clinical judgment and your understanding of these unseen mechanisms is the ultimate safety net when a patient's internal physiology fails. Take these pathways. Visualize the hormones moving through the blood. Remember the exact depth of that rectal thermometer. Understand why that cold blood hitting the heart is so lethal. And you will not only crush this exam, but you will save lives on the floor.